Now we'll start the Q&A here. If you have a question that you've written out, just raise it up and somebody will be around to collect them. You know, Peter, you alluded to Trump's announcements on Friday. I'm wondering if you would like to just take a minute or two just to kind of frame your reaction to it, and then maybe I'd also ask the other panelists to weigh in if it's going to have impact. Stock prices went up. PBMs and pharmaceutical companies' prices went up. What do you think?
Yeah, it's I don't know if I'm on.
You should be able.
Well, I can project. So, you know, we're all watching it very closely. My group generally focuses on the weeds. So we're looking at the different of the 44 or some odd provisions and going to write about all of them, or any ones that we think have substance. I actually think it's difficult to know if Wall Street's called this right. I think
Expectations.
well,
High.
right, exactly. You sort of, you know, sell on the rumor, buy on the news. So the question is if there's going to be follow through on these things. The notion that rebates could be put back in as kickbacks would be highly disruptive. If we didn't have rebates in D, I think it would be inflationary. Because they would continue to exist in private markets, but that would be pretty disruptive. The call for some of the other issues, I think, you know, we're just going to have to see what kind of follow through they're planning on. But they're certainly talking the talk of moving more and more into the private market and trying to get the private market to do its thing. But I didn't hear things like, let's get rid of protected classes in Part D, which is what I would have been looking for if they were serious about really unleashing the market. I'm not sure that's a good idea, by the way, but that's a separate issue.
Great. Anyone else want to comment, have a reaction?
So I'll just add that I was at Secretary Azar's announcement this morning. I think it's a little early to know how it's all going to play out, but Patrick and I both are part of a consortium that owns Prime Therapeutics, and that particular PBM is one that's completely transparent. It's not publicly traded. It's got a bottom line of delivering the lowest possible acquisition cost, and it's really a pass-through cost to the plans that own it. For that intention, we didn't want to be part of the rebate game that you see happening in the rest of the industry, and so I think we're ahead of that curve.
Great. The first one I think I'll go with is about the opioid crisis, as several people have submitted questions on that. What can we do about the opioid crisis? What are you doing, maybe, would be a better one. Patrick, I know.
Yeah, I'll start and others may add in. So as you all know, literally have zip codes in America where mortality is going, life expectancy is going down, largely due to opioid issues. First, I think in broader mental and behavioral health, how do you have a true system that serves people? Two, I think expanding treatment options and opioids through any means necessary, including evidence-based treatments like MAT, Medicaid-assisted therapy. You know, I think three, we are really focused on how we don't have unintended negative consequences, so everything from pain, treatment, and thinking about that, to increasing access to other modalities of pain treatment other than medications, to, we had a story about a week ago based on, we put hard edits into our pharmacy consistent with evidence-based guidelines to prevent overprescribing of opioids. So that's a few thoughts.
So a couple of things. Our plan immediately took action to take OxyContin off of our formulary and say that we're going to drive people to less addictive drugs as one step. We've also worked a process with our delivery system to decrease the amount of medication that's given initially. And I'll be candid with you, I had knee surgery in September, and when I got my 30-day supply, I said, what is this about? You know, I took 1 day worth of painkiller, was not interested in taking more than that, but I got a 30-day supply. Now you've got a drug at home, and it creates the cascading issue that we're all dealing with. So we got on that dosing level, and so I think it takes a lot more than any one stakeholder can do. This is a very big issue, and especially when you get into the drug or illicit doses of the drug arriving in the country from outside of the country direct to the consumer, then it's completely outside of the health system. So it really takes all factors working together to address it.
Great, great. Patrick, this is one for you. With ACOs facing downside risk, what do you see as the future of ACOs? I'm sure others are interested in that.
Yeah, so this has been active on Twitter as
Right.
well. I'm on Twitter too. I was also told I needed to be. Patrick Conway, MD.
I follow you, Patrick.
Yeah, no, but I do think there's evidence in the ACO program that ACOs at two-sided risk on average have done better than one-sided risk. On average, two physician-led ACOs have done better than hospitals and health systems. And on average, people do better over time. That last point sort of cuts both ways. So I think I would try to move the program to more two-sided risk. I also would think about the counterfactual as you do that. So if people completely go back to fee-for-service and aren't legitimately trying to shift the system, that won't help us either. But I would, I think it is reasonable to push harder on two-sided risk after some amount of time, especially for, and I used to lead in hospitals, nothing against hospitals, but for hospital-led ACOs with capital, I think you could say we need to move those type of ACOs into a higher risk arrangement. And I think about small physician groups differently. There's real issues about how much risk a small physician group can take on.
I would say this is a classic example of theory to practice. So at the practical level, when you're trying to get a health system into an ACO, you've got to convince the CEO. They have to convince their board of directors. And by the way, when both of those groups agree, you still have to convince the CFO, who thinks that they're the ones protecting the institution. Most people can see getting to the other side of the chasm. They can't see the transition. They are very concerned about what happens when we start to have less people in the facility and our cash flow. So it's getting people through that transition that is really the critical part of making this happen in the marketplace, which is why most of these start with upside risk only, got to get them comfortable in the new model, and then they gravitate their way through an evolutionary process. Unfortunately, really hard to get most institutions to take a complete leap of faith to upside downside risk from a fee-for-service model that they were in before.
Yeah, sorry, I know you.
No.
I agree with the trajectory point, moving people along a trajectory. I also think there's reality, having been in CMS when we did the program. Like when we started, we didn't know how many people were going to sign up. Now you have, 500 plus. So I think you're at a different phase with additional evidence, so therefore the program can transition.
Great. This is an interesting question from the American Academy of Dermatology, and I just wanted to read where it was from, but it's to the panel. How do you see consolidation in healthcare, and particularly in the purchase of physician practices by private equity firms, affecting the delivery of care to patients in the future? You can answer that in a broader way, too, with the private equity. It's an important trend that we're seeing.
Who wants to go?
Cliff.
All right. Is this thing on? No.
Sounds like it's on. Yeah.
All right, great. It's definitely an issue, and you see more and more, not just private equity firms, but insurance companies and other kinds of providers buying physician practices. I think the key is, I like the way Cleveland Clinic does it, which is that, they're salaried, which is, I think, the best way to pay physicians. And, when you start to, have incentive programs for care, then I think it throws everything out of whack. I think that, I'd also like to say that I think the value paradigm is what's driving all of this to some extent. And I think that there is some confusion about who the value is for. So whether it's for the payer ultimately, whether the value is for the patient, or whether the value is for the drug company, getting, more value on, as Peter said, from that very large initial fee. But I think that fundamentally, I think that as you move more towards, people being paid based on outcomes, rather than the inputs, I think you're gonna have a better situation. And I think that when private equity companies start to buy them, they want, no private equity company buys anything without looking for an exit price and profit. So that's why private equity buys things, so they can get out in 5 years with a profit. So that's probably not a good idea.
Maybe I'll say a couple comments, others may add more. So most of my family members are small private practice docs across America. There is this real issue that's becoming a more challenging environment to succeed in. That's point one. Point two, there's good evidence traditionally when hospitals have bought physician groups or large hospital systems have consolidated, prices have gone up for consumers. And then, therefore, I think the path forward is, at least for our company, and Pat talked about this too, how do you support independent physician practice, both primary care and specialist? At some points it may be through equity, and others it may be through partnerships or contractual arrangements, but how do you support those practices so that they have the capital, the support, the systems to succeed as an independent group, and therefore, aren't sold to entities that are consolidating for other means?
Yeah, again, practice and theory. So if you're a medical group and you now have all kinds of reporting requirements to the government, you have to upgrade your technology. You have to make investments. And many of these practices just haven't been run as a very finely tuned, efficient business. So they look to somebody for that equity piece of the equation. Those that have looked to hospitals have found some disturbing trends there. The medical group we bought actually came to us and said, 2 hospitals are bidding on us. We know whoever buys us is going to require us to put more people in the hospital than we think is necessary. And they wanted to have the independence of not having that pressure, which is why we got in that equation, to learn a little bit. Frankly, I think the best model is when it's physician-owned, but these practices are going to have to be larger than single and 2 or 3 doctors operating alone, just given all of the demands on them. But I think the independence of the physician is actually a good thing, and if we can instill that in our marketplace or support it, that's a good thing, because the pressures of private equity tend to be not in the best interest of patients.
Okay, this will be the last question from Nova Scripps Central. How can we better define the value proposition for culturally competent patient care? What is the role of cultural diversity in fostering innovation? Anyone like to take that? Pat, I know you're doing a lot on.
Well, we have probably the most diverse state in the nation in Florida. We've got people from everywhere. And so cultural competency has been a very critical component of how we think about our organization and how we interface with our marketplace. It is critical to understand what the drivers are of health and health status. And cultural competency is really talking about being aware of the patients that you're dealing with, the social norms that exist around that patient. I mean, in many of our clinics in South Florida, going to the physician is a family event, multi-generational event. And if you have built a standard medical practice, you're not accommodating that patient, their family, and the needs they have in taking care of that family. So it really is about awareness. It's about educating yourself so that you do the best job for your consumer. And it's being aware of the various medical risks that are incumbent in various parts of the population that you're trying to serve.
Cliff, are you seeing anything in terms of a major trend on the diversity, the heterogeneity of our population?
I'll tell you that it's necessary. Just an anecdote. I have a friend, Virgil Simons, who ran an operation where they dispensed prostate cancer information through black barbershops, predominantly African-American barbershops, which was much more likely to end up with a follow-up visit for an older African-American to a prostate cancer specialist than in any other intervention there was. And that's because African-American men of a certain age trusted their barber more than anyone else. And in fact, it was expanded to the fact where professional videos were created to deliver information on prostate cancer at barbershops. It was a great example of how, how the message is the medium in many cases. And, another example is that men who have female doctors are less likely to take their medicines appropriately than men with men doctors or females with male doctors. And that's something that just, you need to look at the data and understand, okay, we've got a problem here and we have to adjust it. So I think it's gender, it's national origin and language, it's ethnicity, it's race, all of these things that we have to be more culturally competent to see better results.
Great. Well, with that, let's wrap things up. Thank you so much for joining us today for this great discussion. I'd like to thank Senator Ron Wyden for sponsoring our event, and I'd also like to thank my great team, Catherine Santora, Kate Ellis, Katie McDonald, Carolyn Myers, and the rest of the team.